Hello, everyone. Hi, Medina. If you want, please use the chat. Feel free to share where you're coming from. We're coming to you live from Clearwater Beach, Florida this afternoon, and very, very excited that you're on today. We're going to let a few more people jump in and we'll be starting. Oh, hello, coming from North Carolina. Awesome. Thank you so much. We got somebody from Alabama. I think I know who that one is. Nice to see you. Thank you so much. And what do you think, Dr. Aziz? Ready to, should we get going? From Orlando, Florida. Awesome. Well, we're close by. So
Yeah,
let's
I
see.
think we're ready to probably get going. Welcome to
Awesome.
everybody. Yep.
So, hello, everyone. My name is Anna Rosanowski, and I'm the Chief Operating Officer of CDIQ Consulting. Welcome to this month, October 2025's free Lunch and Learn webinar. We are going to be focusing on AKI from data to diagnosis today. We appreciate you all being here today as part of our growing CDIQ CDI community. I'm honored to introduce our founder and CEO, Dr. Tarman Aziz, MD, CCDS. Dr. Aziz is a HIM executive, a CEO, internal medicine physician with over 13 years of CDI experience. Dr. Aziz is a nationally recognized AHIMA and ACTIS speaker and educator, presenting at AHIMA's Virtual Coding Summit earlier this year, and also Maryland's ACTIS chapter. Dr. Aziz also took the stage at a HEMA 25 pre-conference in Minneapolis this year, which was a huge success. We just arrived back from there last week, and like I shared, it was a huge success. We networked, and he was live on stage. Make sure you check out also his article on advanced documentation integrity, policy strategies for acute ATM capture, and risk adjustment in the Journal of AHIMA from May 6th of 2025 this year. Dr. Aziz, please take it away. Thank you.
Thank you so much, Anna. Appreciate that generous introduction and welcome to everybody. Thank you so much for joining us on your lunch hour. If you're from the East Coast or if wherever you are in the country, welcome your attendance today. We're going to be talking about a subject which is so common in CDI, which is AKI. And to do so, we are going to just briefly go back to our basics because the basics really matter here. If you recall, the kidneys, each of them have about 1 million nephrons, and they're arranged in such a way to filter the blood. You can see the blood coming in and out of the glomerulus. That efferent arteriole, of course, continuing on is the peritubular capillary system. We see it nicely illustrated here, which allows for the reabsorption and secretion of different substances as they move through the nephron. Do we want to hold some of that back into the bloodstream, reabsorption? Do we want to eliminate more of something, secretion from the bloodstream into the nephron's lumen to be ultimately excreted? So we all know the physiology. We remember that the proximal tubule wants to take back everything it can from the freely filtered contents at the glomerulus, and it does so. It takes a whole bunch of substance back. The distal convoluted tubule and the collecting duct are where we're most interested for today's discussion around blood urea nitrogen. Of course, thankfully, we have a liver that has a urea cycle, or would become poisoned pretty quickly with the breakdown products of the protein that we ingest. And so still, we have to consider what happens under the influence of things like diminished renal blood flow. And we know that we're able to reabsorb more or less uh, BUN, more or less of the urea uh, differentially across the duct and across the DCT. We also know that we can use creatinine concentrations to give us a reasonable estimate of the GFR if we're to measure both the urinary and the plasma levels. So that's basic physiology. The key thing to remember is under the influence of ADH, really, antidiuretic hormone, which assists that renin, angiotensin, aldosterone release whenever the kidney sees diminished blood flow, we're going to see differential amounts of urea being reclaimed into the bloodstream. And so that matters because it's going to end up affecting the BUN to creatinine ratio. So the good news out of the slide here is this was only a brief reminder of something you've left behind, how the kidney works, how the nephron physiology works, and how normally we should see a serum BUN, blood urea nitrogen, of around 10 to 20 milligrams per deciliter, and a serum creatinine of around 1 milligram per deciliter. So from that, we can talk momentarily about ways in which you can maybe up your game with AKI. I'm sure everybody on the call can share something about acute kidney injury that perhaps has frustrated them in their CDI studies or in their CDI practice or even in managing a program. We'll get to that in a moment. What I'd like to do today is make this a bit more academic and think about ways we can also expand our AKI practice. For example, just by a show of a yes or no in the chat box, how many of you have received feedback if you send queries about AKI as part of your role? How many of you have received any feedback about the timing of your AKI query from your leadership? Can anybody either take the microphone and share an example? Okay, good. Keith, Elizabeth says yes. Keith adds not only yes, but too early. Good. Can you expound upon that idea a little further for us, Keith? I think I know probably what you mean there. Why might it be a little too early to send an AKI query? What might we need to have waited for first? We all know about the KDIGO criteria and the ways in which we can justify sending AKI queries from a given case. So if you didn't have a baseline creatinine agreed, that would be a difficult thing to assess. And let's say we don't have the past medical history. Maybe this patient is new to your health system, so you can't set the EMR back a year and hope to see some old data. What are we meant to do then for baseline in the absence of anything other than the current admission to work with? We're meant to use the lowest serum creatinine measured in that admission. So how would you know if you are 1.5 times the baseline at the time of admission to the hospital for, say, a POA AKI? Or how would you know you're 0.3 milligrams per deciliter higher than baseline within 48 hours for a newly developing AKI within the admission itself? You wouldn't know unless you've had a reference point. So that could be a reason you're still establishing baseline and you don't know the magnitude of the serum creatinine change. Why else might you need to delay the sending of an AKI query? Let's say you think as a CDI specialist, AKI is evidence because they used vancomycin to treat MRSA on admission, rip-roaring MRSA. So you see an AKI developing just by the numbers, by the serum creatinine change. And you also notice they've now withheld vancomycin and put on something different for an antibiotic. When do you query? Do you query right away, noting that there's been an antibiotic change that day and noting that that day you've met criteria? Is that a good idea? Why or why not? To go ahead and query that same day. Somebody I'm sure out there knows what I'm. Yeah, right. Very good. We should wait to see if the serum creatinine actually decreases in the face of removing the offending nephrotoxic agent. Absolutely correct. just like if the patient had severe dehydration from a violent bout of diarrhea or a profound hemorrhage of some sort, and you've suspected a pre-renal mechanism, perhaps for AKI, and you see that all the numbers make sense, wouldn't you want to let the provider hydrate the patient aggressively, wait for the serum creatinine to come down, and then query for AKI? So that hand on heart, the provider could rationalize the mechanism to themselves and then turn around and give you an honest answer. So most of the time, the auditing side of the AKI query world is quite easy. First of all, take a look at when the query was sent. The younger the CDI specialist may be in terms of their career, the newer they are in that role, the more likelihood it was sent too quickly as a gut reflex to the laboratory indicators being met. On the other side of the fence, we see some novice CDI specialists are concerned not to send the query in because of the use of language like renal insufficiency. And they think, well, the serum creatinine's right on the border for the KDIGO qualifying changes. Maybe I'll hold back. So there could be any of you on the call, depending what level of CDI practice or interest you're in, might resonate with some of these. Others of you that haven't started working in CDI may still be learning those ideas. It doesn't much matter. We hope to address everybody today, and we appreciate your attendance. Let's get into some of the details beyond the speculation, but thank you for the comments. We're going to want to multiply the lowest number by 1.5 rather than 1.3 to make sure we're at least 1.5 times the baseline serum creatinine for that retrospective look at if AKI was present on admission, for example. Or we're going to want to add 0.3 to the baseline for our within 48 hours threshold for uh, developing AKI that's not POA. We'll take a look at that in a moment. Here's another difficulty that we can face in CDI work. Clinical language may occasionally be at odds with ICD-10 coding guidelines. Here's one such example. I once attended a talk at an academic medical center where I was a consultant, and the speaker was very aggressively commenting that the term pre-renal azotemia was being used as a pushback by physicians who didn't want to commit to AKI, and they were being a little bit slippery in their response to the AKI query process. But in that case, I felt it would be only right to defend the physician because, much like myself, uh, was trained clinically from textbooks that suggest that there is the normal healthy kidney, then there's a kidney that becomes at risk of acute kidney injury or acute renal failure. And then you could fall out of that into two possibilities. You might have pre-renal azotemia that's accompanied by a marked increase in serum creatinine and an accompanying decrease in GFR to be expected, with some urine output then that's down, but you don't see the cellular injury biomarkers, as opposed to where you do see those biomarkers. The differentiation there was between so-called functional AKI and structural AKI. So one clinical paradigm or one perspective or lens through which AKI is taught to clinicians is you've got a pre-renal azotemia form of AKI that's there, and the serum nitrogen is rising, but we have yet to see evidence of the kidney actually suffering from a structural standpoint. We don't see casts, for example, in the urine yet or anything like that. So that's a little bit of an old-fashioned paradigm compared to some of today's thinking, but enough physicians out there in practice were taught that way. So don't think necessarily the use of the words free renal azotemia represent passive aggressive pushback to a query about AKI. A provider may genuinely not know that those terms are not synonymous. From a coding perspective, we know azotemia doesn't do us a whole lot of good. Certainly doesn't pick up the N17.9 code for AKI. So that's one consideration. The other consideration when thinking about clinicians and how they think about AKI is mechanistically. And here's where CDI and clinicians can happily align, I believe. We can make a case for it. So we have the blood flow from the aorta to the renal arteries and ultimately the branches of which will start feeding the nephrons. So anywhere along that blood flow to the kidney, uh, could present a pre-renal mechanism to acute kidney failure, sudden and severe drops like shock, or even interruption of blood flow to the kidneys. You could have renal artery stenosis, for example, from ongoing atherosclerosis. We always think about coronary disease, but what about renal artery disease secondary to hyperlipidemia? Certainly possible. We also have secondary intrarenal secondarily on this diagram anyway, an intrarenal possibility, meaning the kidney itself is the site of damage and failure. Could be inflammation, it could be autoimmune mediated, it could be toxin related to a drug or other exposure. There are certain infections that may target the glomeruli, for example. And again, with prolonged reductions in blood supply, sure, we could see more of an AKI with ATN pattern that suggests intrarenal damage. Finally, post-renal, we can think of anywhere numbered 3 on the diagram. So after the kidney, within the ureter or within the bladder or the urethra, particularly the prostatic portion of the urethra in men, where benign prostatic hyperplasia can put pressure on that portion of the urethra. The idea is whether it's a large prostate or renal stones or repeated infection with nephrolithiasis and ureteral involvement with stricture formation from chronic inflammation and fibrosis. We can think of any number of things. Transitional cell carcinoma of the bladder with masses causing obstruction. That increase in pressure will be felt in a retrograde fashion, and reduced GFR will secondarily lead to vasoconstriction of both the afferent and efferent arterioles. So the kidneys don't do well in that setting. And so we really like to think clinically about why did the AKI develop in the first place? And for CDI specialists moving through their day, and with a chart quota, this many new cases, I got to open them and to say something intelligent about them. I've got to open all my follow-up cases. My goodness, there's so many of them. How will I prioritize? Probably not at this point in the discussion thinking, great, let me become a scholar of all possible mechanisms for acute renal failure so I can contemplate these in a subtle fashion during my chart review. That would not be a popular message for me to convey to this audience today. And in no way am I suggesting you do that. But I am going to suggest that you exploit something very simple that comes with every one of those chemistry labs that you're reviewing on a daily basis as part of your chart review, which is simply to look at the BUN to creatinine ratio. Because oftentimes we don't stop to calculate the BUN creatinine ratio, just like we do with respiratory failure, right? If we're thinking, could this be acute respiratory failure? I'm looking at that ICU patient. I might stop and look at a PF ratio and see if the PF ratio aligns with acute hypoxemic respiratory failure. Maybe it even aligns low enough that it aligns with acute respiratory distress syndrome or ARDS. Not as often, and of course, you don't include those PF ratio calculations on the query. That's not compliant, but it gives you confidence to send the query, let's say, if you're on the border about the acuity of respiratory failure. Now, coming back to our topic for today, why not do the same thing for acute kidney injury or acute renal failure and think about the BUN creatinine ratio as it relates to these 3 mechanisms, because it may either strengthen your conviction to send in a query, or if AKI is already established and you don't need to send the query to get it on the record, but rather maybe you're looking for additional query opportunities, the mechanism in which AKI has developed may actually help you. to carve out those additional query opportunities. So two utilities to thinking about the way in which AKI developed. Utility number one is feeling strong enough to make a case for sending a query to establish AKI when it has yet to be established, despite compelling indicators. The other is to look for additional queries that may be illuminated by the mechanism. So that's the rationale for going into this story. So in general, we know that when the serum creatinine rises dramatically above baseline, that's no longer, probably anyway, dehydration or azotemia or acute renal insufficiency, or my least favorite, the creatinine bump, which is really just hard to accept from providers who write that because there is no good clinical analogy for that. That seems to be avoiding the issue. But anyway, they all deserve, when the creatinine is rising dramatically and the pattern would suggest truly AKI, they deserve to be called as such. Acute renal failure, acute kidney failure, acute renal injury, acute kidney injury. The injury and failure are interchangeable. The renal and the kidney are interchangeable. The acute is not. The acute must be there to get the proper severity capture. This is a CC diagnosis when it's unspecified. And as we know, it becomes an MCC diagnosis when specified as something like AKI with ATM. We need the acronym, basic CDI principle, nothing shocking. Acronyms should be spelled out at least once in their entirety in a record before used beyond that by the admitting team. They don't want to, but they should. We're using the kidney disease improving global outcomes guidelines. Most of us in the industry are no longer messing around with Aiken and rifle criteria and older classification systems, although this one is old as well. And there have been some supplements and revisions added to KDIGO. Most of us are still using this 0.3 above baseline, or in hindsight, 1.5 times baseline, or a urine volume less than a half cc per kg per hour for 6 or more hours. And notice the word or in a couple of places there. You could just have the urine output down and have no information about creatinine and pick up AKI from an indicator. Now, usually you have the serum creatinine, but too often people are looking for all of these or two of the three to be met, and that's really not necessary. Any one of these. Again, the lowest in the admission, ideally the lowest recorded creatinine found for the patient in the last 3 months would be a better baseline per KDIGO. So what about the BUN creatinine ratio then? Having said what we all know, that's the last slide, just common ground information about AKI. So I don't want to spend too much time on things that are so well known, but few of us slow down, it would seem, to think about the BUN creatinine ratio. We can get the numbers easily from the daily labs, and they can help us to assess what the cause might be or what the association might be. Now, with the reference range of anywhere from 10 to 20 for a normal BUN and around 1 for a normal creatinine, that makes the range for the BUN creatinine ratio itself anywhere from 10 to 1 to 20 to 1 as a normal ratio. You can see that it varies. I've mentioned here based on which lab methodology is used. It also varies based on source. So this particular source favors 12 to 20 rather than 10 to 20 with a 15 optimum. That's just one perspective, but you get the idea that there's a range. There's could be way too high or way too low or right on the range. And so it becomes interesting then to consider what would be the acute kidney injury settings for different types of BUN creatinine ratios. Right away, we can see in the middle here, high. The BUN creatinine ratio is high for pre-renal uremias and high protein intake and after GI bleeding. So this is that typical pre-renal azotemia pattern that we see. That's a lab finding, pre-renal description of a lab finding, how you came to be azotemic. So with a high BUN creatinine ratio, you have a stronger suspicion of that pre-renal mechanism number one. Whereas if it's a low BUN creatinine ratio, think more about ATN, uh, the more severe form of illness. We're looking for at least a 72-hour elevation in serum creatinine above what would have qualified for KDIGO criteria for AKI. 72 hours of elevation in that serum creatinine, despite adequate IV hydration efforts, which would then rule out this pre-renal mechanism. Or it could be that it's low because of a lower protein intake, or from starvation states, or from severe liver disease if the proteins are not being made. But ATN we think more about for acute inpatient care with a low BUN creatinine ratio suggestive of AKI. Okay, with post-obstructive, like the urinary system obstructions that we considered, you can think about a high BUN creatinine ratio with a high creatinine initially. But as the kidney injury wears on, this will actually normalize. So more often than not, we actually see, despite what the diagram shows us, these earlier findings in the course of obstruction. With obstruction, we tend to see a normal BUN creatinine ratio. And for all of these, why are they high or low? Just depends on the mechanism. We're not going to spend so much more time on mechanism today in the interest of getting to a few examples and most importantly to your questions about AKI at the end. So just to quickly go through this then, BUN creatinine ratio high, greater than 20:1. Think pre-renal. You can run the numbers yourself and trend out the BUN creatinine ratio to see how they're doing with this type of disease, if this is the mechanism. There's a disproportionate increase in BUN compared to creatinine. So there's reduced flow to the kidney. We're going to trigger the reabsorption of more water and urea to try and conserve volume. That's all under ADH's influence. And there's a little bit faster increase in BUN compared to creatinine. So the ratio, at least for a little while, should be higher than that 20:1. If you have a nephrologist on the case and they've bothered to order urinary lab work, which we know not every case with AKI is blessed with the nephrologist's insight and all the good urinary data, you might see findings like a low urine sodium below 20, a fractional excretion of sodium less than 1%, and urea, a fractional excretion of urea less than 35%. Okay, so the point is, so what, as a CDI specialist, I think this AKI is pre-renal. But if you're trying to get it on the books, it helps that if all you have is a pre-renal mechanism for your suspected AKI, you better make sure that BUN creatinine ratio fits the picture because the clinician will likely be thinking that way, even if they're not saying so on their query response. Secondly, you should ask yourself why. Does my case fit either a volume problem, like one of the four listed here, or do I fit a perfusion problem because of a redistribution of blood flow from sepsis or a cardiogenic shock or exacerbation of heart failure? If you have hemorrhage or vomiting, diarrhea, burns, is there something that you can think is associated with that? And in doing so, you may be going back towards the principal diagnosis and doing so with this AKI serving as your secondary. Maybe you're then recasting that PDX in a different light and thinking of additional queries related to these conditions. Is there an acid-base disturbance related to the vomiting and diarrhea that you didn't think about, right? Is there a hemorrhagic shock that you haven't noticed that the pressors are on board in your hurry to look at something else? You didn't check the medication administration record as thoroughly as you should, and you miss an opportunity to query for a what would qualify as shock, not just refractory hypotension, as might be written down over and over on the medical record. So you get the idea that there could be a number of targets quickly opened up if you use this logic and say, fine, there's a creatinine change. I think it's probably AKI. But if you push yourself to take it to the next step, what kind, you may find there's more on your plate. You certainly want to use the ratio to rule in the notion of AKI in general. For intrarenal, uh, the creatinine, the BUN creatinine ratio will be less than 10.1, so it will be a low ratio. Damage to the kidneys, tubules, will impair their ability to reabsorb both urea and creatinine effectively. Remember, urea is fine to move around, but it still uses passive diffusion. So it will be affected when there's ATN channels will be affected in an ATM picture for intrarenal, for example. And so while the creatinine levels rise due to decreased filtration, there's impaired reabsorption of urea as well because of the damage. And so it doesn't rise as disproportionately. So you get a slightly lower BUN than you do creatinine, and that will make the ratio low. Here we see differential findings to the last case. Here we have a high urine sodium, high fractional excretion of sodium, and high fractional excretion of urea greater than 30%, 50% rather. So the opposite story to pre-renal. Again, ask yourself, do I have AKI? Does it look like it could be? I'm guessing it's probably intrarenal from the details of the story. All right, I see some details here that help me confirm it from urinary data. Fine, what am I actually dealing with as the core mechanism? Okay, if you have a vasculitis ongoing that's autoimmune, is the patient on chronic steroids? Does that cast a new light on the high white blood cell count that you were thinking about using for a sepsis query? Does it recast anything else in the case? The renal artery stenosis, is the patient possibly going to get that stented as part of this visit? Should you put a note to yourself to look out for a stenting procedure? Is there a history of streptococcal infection, and what are the possible consequences of that infection on the case if they're suspecting a post-infectious glomerulonephritis? Or if there's ATN, why is there ATN? Is there an associated acidosis? Is there an associated hyponatremia or hyperkalemia that needs to be picked up and is not being diagnosed? So you can see the idea very quickly of the additional utility of studying this. With post-renal, eventually you should get around equal to a normal BUN creatinine ratio. Okay, both numbers are elevated, but they're pretty much equally elevated. The problem is beyond the kidney. There is no filtration issue. There's no reabsorption issue. It's an issue with back pressure from the urinary system. And eventually, over time, that slightly elevated BUN creatinine ratio should come down to normal, but both numbers are abnormal. The point is, it's just the ratio is normal. Here, you'd want to know exactly what's going on, which part of the urinary system is implicated. You can imagine a host of possible queries related to these. Is there a malignancy that's not been clarified as a CC diagnosis? Bladder, prostate cancer, perhaps a metastatic malignancy from nearby that's invaded these structures? Is there retroperitoneal hemorrhage or hematoma that's led to an abdominal compartment syndrome? Uh, is there extensive nephrolithiasis such that there's dilation? So there's maybe hydronephrosis, maybe there's also pyonephrosis. So you can think about all the rollout secondary conditions that could be related to AKI if it's a post-renal mechanism as well. The idea is to become scholarly with your records so you can consider alternate principal diagnoses as well as just straight CC, MCC capture, and becoming a little bit more scientific about the AKI can potentially help you do that. Let's look at a few cases here to bring some of this together now. A 47-year-old lady comes to the ED with complaints of fever, chills, cough, and green sputum. That sounds pretty ill. Myalgias and weakness. Tachycardic with a maximum temperature to 102.7 Fahrenheit. hypotensive, requiring 4 liters of IV fluid to normalize the blood pressure. The white count initially at 28.7 with initial workup showing a sepsis due to multilobular pneumonia. Patient noticed urine had been very dark. Initially, BUN and creatinine are 32 and 3.8 respectively. Last recorded BUN and creatinine were 19 and 0.8 at the primary care provider's office 2 months earlier. So clearly we're well above baseline. UA reveals large amount of protein and numerous epithelial cell casts. So we're seeing that sign of injury. BUN and creatinine almost normalized by the time of discharge. So here we have an intrarenal form of disease, as indicated. The patient was actually admitted for sepsis. We can see they were very sick with some SIRS indicators present, and acute renal failure. Acute renal failure was a diagnosis on this record for a long period of time. The CDI specialists put themselves through a simple algorithm approach. Is there acute renal failure? Does it qualify? Yes. We're more than 1.5 times the baseline. We only needed to be at 1.2 to be above that threshold, which we easily beat. The ratio is at 8.42, which is low for an intrarenal. Does the urinalysis help us? Yes. Epithelial cell casts confirm potentially an ATN. ATN would match with intrarenal with a lower BUN creatinine ratio, and in fact, that prompted a query opportunity for AKI due to ATN, because while the BUN creatinine ratio wouldn't be listed on the query form, the specialist sent the query with a little bit more confidence, knowing that that ratio could be used in a discussion, a verbal follow-up with the provider to get that on the record. So especially if you're right at that border of the 72 hours, that's a very helpful piece of additional information to have. All right, another case, 86-year-old man with Alzheimer's, dementia, CHF, coronary artery disease, and peripheral vascular disease, comes to the ED from a skilled nursing facility with lethargy and unresponsiveness. The initial workup showed a sodium very high at 167. Okay, so we see some abnormalities in electrolytes, chloride 118, potassium 55, BUN 79, creatinine 2.6. The lowest recorded on BUN and creatinine, 29 and 2.4 respectively, was discharged for diastolic CHF exacerbation just 6 weeks earlier. Okay, so we know those who are discharged with acute CHF exacerbations, unfortunately, are prone to readmission quite quickly with the same problem and with a borderline kidney function that's going to cause major issue, most likely. Urinalysis significant for numerous hyaline casts. Recently, the GFR was 17. The patient has been aggressively hydrated, and BUN and creatinine return to baseline. So we're dealing with advanced CKD as well here. Patient was eventually discharged home. If you run the numbers on this case, what do we see? Patient was admitted for acute renal failure. Does the patient have acute renal failure? Well, it's tempting to say so with 2.6 serum creatinine, but if you run it against the baseline, it's actually only an 8% elevation above that baseline. So clearly not 1.5 times or higher. So there's a pre-renal pattern here. The BUN creatinine ratio is well above 20, well above 25, so well above everybody's reference range for the ratio. So it suggests a pre-renal mechanism, but the magnitude of serum creatinine change, given the elevated baseline value with severe CKD, is not convincing of AKI. In fact, this would be a good clinical validation opportunity to clarify if this was really more like acute renal insufficiency on CKD stage 4. So there you'd want to pull back, adjust your query process in light of the fact that the lowest recorded was 2.4. It's easy to forget if the baseline is that high, that AKI may be a reflexive piece of documentation that doesn't actually belong there. There's already CC impact coming from CKD4 on that chart anyway. So it's not as though you really have to have that there. So too many forced issues there with CDI AKI queries, a little bit too aggressive has been my observation more often than not. All right. Finally, 63-year-old man comes to the ED with painful urination, uh, difficulty initiating the urine stream, hematuria, weakness, 4 months of weight loss without diet or exercise, no physician visit for 25 years. And CT of the abdomen and pelvis shows bilateral hydronephrosis with markedly enlarged and necrotic appearing prostate with pelvic lymphadenopathy. Okay, so this is not BPH, but this is a mass that appears to be a malignancy. Initial BUN and creatinine noted to be 55 and 3.3. Foley catheter insertion results in significant diuresis, and the final BUN and creatinine are 18 and 1.1. UA was within normal limits except for a little hematuria. After biopsy, principal diagnosis established metastatic prostate cancer with a radical prostatectomy required. Here, the ratio works out to be basically a normal number. It may have been a little high if you looked at the earliest numbers, but in this case, it did normalize rather quickly in line with a post-renal. Even though both numbers are markedly elevated, the ratio itself is normal. That's classic with obstructive. The quick correction with relief of obstruction using that urinary catheter further helps that. Urinalysis was not that helpful because not to the AKI mechanism from the hematuria itself, but it did give us a clue to the underlying obstruction. So there was a query opportunity here because AKI was not being documented. It is helpful to ask providers to clarify etiology, at least a pre, intra, or post-renal mechanism. I don't see that question included as a standard part of most AKI queries, and I understand why. We like to keep the queries as simple as possible. You may negotiate that to be added into the query process. It does help to make them a little bit more denial proof because we know that some payers deny AKI even when the query gets a positive response, yes, AKI. The payer may still write in their denial letter, we don't think so, and this is why. So if you force the provider to actually say pre, intra, or post-renal mechanism and to clarify that mechanism as part of their ongoing documentation, AKI becomes a lot harder to deny payment for. So it's another reason to think about the BUN creatinine ratio today as just an additional and simple toolbox item that you can use. Just to wrap up a few additional points from my side, and I'd like to turn it over to you for questions. AKI specificity query is not the query to use when you're trying to get AKI on the record. When we audit CDI department efforts and look at their chart performance, it's remarkable to me how often I see this query template used, and AKI is not mentioned anywhere on the record. We're only meant to mention these choices and use this template when AKI is already established, and there are indicators suggesting one of these more specific types of acute kidney failure may be warranted. Even if it is, you want to go ahead and remove the choices that don't pertain to your case. So if there's nothing to support cortical and medullary, which oftentimes there are not, then you need not list them. You could just start with the ATN and then the other type, please specify, and the other cause and all the other disclaimers. But note, please include documentation of this particular program uses. Please include documentation of underlying conditions contributing or causing the renal failure. So there's a call out to that mechanism in this particular query template. We know templates vary from facility to facility, so consider if you would include that along with the POA question in your queries. But for establishing the case, we want to see something more like this. Uh, Clinical significance or clarification of clinical or lab findings or whatever you call it at your facility, right? Here are the numbers. Here's what you've told us, something about azotemia, dehydration. What's the clinical significance of all of this when you really think about it further, dear provider? Is it A, clinically insignificant? That's sure about as compliant as you can get, right? You just tell them all this nice information and say, what do you make of it? Nothing? Okay, I'll leave you alone. Was there a lab error? Was there pre-renal azotemia? Was there some form of AKI? Tell us how. So these are all possible depending on the details filled out in the top half. We hope that you wouldn't use lab error if it's not likely. We hope you wouldn't use pre-renal azotemia if it's not likely, and that you would remove any mechanisms if they're not supported by the facts of the case. If you have no obstruction, you wouldn't give post-renal as a choice. If you have no chance at ATN, remove it and any other intrarenal choices from the query template. So trim the template and use the right template. For staging, oftentimes we roll our eyes as well at staging of AKI. After all, whether you tell me it's AKI stage 1, 2, or 3, I'm not going to get a lot of coding utility out of it, most likely. But you are speaking to the severity of illness. And one place that really matters is where, when we're looking at sepsis cases. So with sepsis, increasingly, we're looking for the organ failure that justifies sepsis. So if you look at the SOFA criteria, you get an extra point right away if the creatinine is at that stage 2 level of 2.0 and higher. So it's good to know what stage of AKI the patient is at, because if you're going to bother later on linking AKI to sepsis, let's go ahead and make sure that mentally we're giving enough points by shouting out that we did have a stage 2 AKI with, let's say, 2.1. Serum creatinine would get us to the 2 points that we need to endorse sepsis right away, just from the serum creatinine. If it is a case, it's linked etiologically back to sepsis by providers. All right, so specificity does matter. It doesn't matter if stage 1, stage 2, and stage 3 all give you N17.9. Push yourself further. Ask if it's pre-renal, renal, or post-renal. So follow those steps. We've talked about this already. We haven't talked about the end of it, which is urinalysis. How can urinalysis be helpful? Sometimes it is and sometimes it's not. It depends if the sample is contaminated, if it was a good sample taken at the right time in the stream of urine being voided. Pre-renal may have hyaline casts. Intrarenal, you might see significant proteinuria. You may see more cellular elements. You might or might not see the muddy brown casts. ATN is really a bit of a misnomer. Remember, it's acute tubular dysfunction more than it is necrosis. Usually the cells are not dying. Post-renal, oftentimes a UA is not helpful. There's not much going on in a post-renal. You may see some trace hematuria depending on the cause of obstruction. For example, a severe nephrolithiasis irritating the bladder and urethra. Certainly you could see some hematuria there. What if you have a sub-AKI rise in the serum creatinine? Well, keep watching it. You might see that they do manifest AKI, but along the way, what fills up this question mark between having a normal baseline for the patient and having the elevated serum creatinine of, say, acute renal failure? We might just have azotemia. There's a code for that. We might have dehydration. There's a code for that as well. And we want to remember all the accompanying electrolyte disorders. And with azotemia, you'd want to ask yourself, is the patient actually uremic? What is the clinical picture telling me? They may have then acute renal insufficiency as a result of dehydration and azotemia as evidence. But that, again, codes only to disorder of kidney and ureter, which has neither CCMCC nor HCC value. So it better be really sub-threshold to bother documenting acute renal insufficiency. Too often we see this last item, acute renal insufficiency, where it should say AKI by the numbers. For uremia, you'd want to see a bigger clinical syndrome, a clinical manifestation, which we don't have time to get into all the details here today, but you can see a number of organ systems are affected in a true case of uremia. And oftentimes that's one that needs clinical validation, or the term uremia is used where really they're just indicating acute kidney injury. The problem again is that it doesn't work out for the translation and coding. As we saw back here, there are other codes like uremia not otherwise specified if it's not benched to anything else. All right, so before I turn it over for questions, just mentioning that we do have our comprehensive CDI apprenticeship course. It's offered across a learning management system, about a 3 to 4 month process, depending on your frequency of class meetings or self-paced scheduling. We accept all forms of payment, including monthly payment programs with different vendors to make it affordable for you. We have programs starting every 2 weeks for most of our programs that you see the first 3 there. We have them scheduled throughout next month into December and early January. We have self-paced for pretty much everything we offer in terms of education, including customized live online classes. If you can't do Mondays and Fridays from 7 to 9 with a third class on a Saturday from 9 to 11 a.m., we can oftentimes customize a 2 to 3 day a week schedule that does work for you. If you don't want any courses and you just are looking for hourly coaching, we offer coaching bundles and individual hourly sessions for all levels of operations and CDI, from C-suite and physician leadership through to program leaders, CDI specialists, and those looking to take their certification exams. For the next Lunch and Learn webinar, we're looking to hear from you. We have our ideas for what we could talk about on Tuesday, November 18th. We're going to have the next one of these a little sooner than 1 month out. We're going to push it to 3 weeks, 1 week earlier. So 3 weeks out at November 18th, so that we don't roll into too close to Thanksgiving. So feel free to send us an email, and the balance of the week ahead will take your requests under consideration for next topic. As far as your questions now, I'm welcoming any of those. I have time to stay a little later than 1 o'clock if we have enough questions, but thank you for listening.